Welcome to The Explainer. Today, we're jumping right into a huge challenge for all of us in endocrinology, the fallout from immune checkpoint inhibitors. Specifically, we're tackling two of the trickiest ones, adrenalitis and hypophysitis. Okay, get this. Up to 95% of our patients on these drugs are going to have some kind of adverse effect. So, this isn't some rare footnote-type complication. It's a massive clinical shift, and it's landing right in our lap. All right, so in our last explainer, we really dug into ICI-induced thyroiditis. If you missed that, check it out. But today, we're narrowing our focus to the pituitary and adrenal glands. We're talking hypophysitis and primary adrenal insufficiency. Two conditions that, as you know, can be life-threatening if we're not on top of them. Okay, so before we get into the nuts and bolts of diagnosis and management, let's do a super quick refresher on the why. How do these drugs actually work, and why are they causing all this trouble for the endocrine system? So it all comes down to releasing the brakes on the immune system, right? You've got your CTLA-4 inhibitors, which basically supercharge T cells back in the lymph node. That's the priming phase. Then you have your PD-1 and PD-L1 inhibitors, which let those amped-up T cells go wild in the tumor tissue itself, the effector phase. It's brilliant for fighting cancer, but, and this is the big but, it's a total double-edged sword. That systemic immune activation means our endocrine glands can become collateral damage, caught right in the crossfire. All right, let's do our first deep dive, ICI-induced hypophysitis. And right off the bat, I'll tell you, this isn't exactly the classic autoimmune hypophysitis we learned about. It's got its own unique flavor. So how common is it? Well, with anti-CTLA-4 therapy, the incidence can shoot up to 17%. That is not a fringe side effect, folks. It's something we absolutely have to be looking for in these patients. Now, the timing here is a huge clinical clue. It really depends on the drug. With the anti-CTLA-4 drugs, you're looking at a pretty early onset, maybe around 10.5 weeks. But with the anti-PD-1 or PD-L1 agents, it's a whole different story. The onset is much later, much more sneaky. We're talking a median of 27 weeks. So you can't let your guard down. So what are we looking for? Well, you're going to hear about headaches, nausea, fatigue, the usual frustratingly vague stuff. But here's the absolute key. The picture is dominated by secondary adrenal insufficiency. 95% of these cases have ACTH deficiency. And another really interesting clinical pearl, it has a clear male predominance, which is a total flip from the classic lymphocytic hypophysitis we typically see. Okay, so diagnosing this really comes down to the labs. You're looking for that classic combo. Low morning cortisol with a low, or what I call an inappropriately normal, ACTH. Now, about imaging. Yes, an MRI might show an enlarged pituitary, but, and this is so important, a normal MRI does not exclude the diagnosis. Don't let a clean scan fool you. And this leads to the million-dollar question for management. For pretty much every other itis caused by these drugs, what's our first move? High-dose glucocorticoids, right? But does that actually work for hypophysitis? Well, the answer, according to the European Society of Endocrinology, is a pretty resounding no. There's just no good evidence that blasting these patients with high-dose steroids does anything to reverse the damage. Why? Because that ACTH deficiency is almost always permanent. So the bottom line is, unless you have someone with vision changes or a killer headache from Mass Effect, you should reserve those high doses. The real goal here is just physiologic replacement. Okay, let's switch gears now and move from the pituitary down to the adrenal glands. We're talking about primary adrenal insufficiency, or adrenalitis. It's less common, for sure, but it is a whole different ballgame. And this right here is the absolute key to telling them apart. Look, in both cases, cortisol is going to be low, but the ACTH, that's your fork in the road. In adrenalitis, the pituitary is screaming for cortisol, so ACTH is sky high. In hypophysitis, the pituitary is the problem, so ACTH is low or normal. Simple as that. And of course, that's why you only have to worry about things like hyperkalemia in primary AI, because the mineralocorticoid pathway is intact in secondary. So with combination ICI therapy, you can see primary adrenal insufficiency in up to 7% of patients. Yeah, it's rarer than hypophysitis, but a 7% risk for a condition that can kill someone if you miss it, that's a big deal. The timing on this one is all over the map. Yeah, the median is around 10 weeks, but look at that range. It can happen as early as 1 week in or as late as 36 weeks. That unpredictability means we have to stay vigilant the entire time they're on treatment. And here's the scary part. The symptoms are super nonspecific. Fatigue, nausea, dizziness.
And get this, up to 90% of these patients can present in a full-blown adrenal crisis. 90%. So your index of suspicion has to be through the roof. If you're even thinking about it, check that morning cortisol and ACTH. The hallmark is unmistakable. Low cortisol, high ACTH.
So if you even think a patient is in adrenal crisis, the rule is simple. Do not wait for labs. You draw the blood for cortisol and ACTH, absolutely. But then you immediately give 100 milligrams of hydrocortisone, IV or IM, and you start hammering them with fluids. We can figure out the diagnosis later. You treat first, ask questions later.
Okay, let's wrap this up. What are the big, practice-changing takeaways we need to remember when we walk into the clinic tomorrow? Takeaway number 1, this damage is permanent. Unlike some other itises that can resolve, these endocrinopathies are for life. The gland is gone. So we need to be clear with our patients from day 1 that they're looking at lifelong hormone replacement.
Number 2, and I'm going to say it again because it's so important, high-dose glucocorticoids do not reverse the endocrinopathy. This is a huge departure from how we treat, say, colitis or pneumonitis. Our job here is replacement, not suppression.
Takeaway number 3 is endocrinology 101, but in this context, it's a life-saving reminder. You always treat the adrenal insufficiency before starting thyroid hormone. If you give levothyroxine to an ACTH-deficient patient first, you can literally precipitate a fatal adrenal crisis. So cortisol first, always. And finally, number 4. This is maybe the most important message we can give back to our oncology colleagues. A controlled endocrinopathy is not a reason to stop their cancer treatment. Once we get them on the right hormone replacement, they are good to go. We can manage this.
So where do we go from here? Well, the next frontier is trying to get ahead of this. Can we actually predict and prevent these toxicities? People are looking at everything from HLA typing to autoantibodies, trying to figure out who's at risk before their glands are destroyed. That's the real question, isn't it? Moving from just managing the damage to stopping it before it even starts.